The COVID-19 pandemic has lasted longer than we thought and much longer than we wanted it to. Why did it happen and who's to blame? This is Scienteens, and that's what we'll discuss in today's interview with Dr. Gagandeep Kang. Dr. Kang is one of India's best public health experts, well known for her analysis of COVID's medical side as well as her critical reviews of how the pandemic has been managed. Today, we'll talk about what could have been done to prevent it and what lessons we should take for the future. Dr. Kang also explains her own specialization in microbiology and experience of pursuing it in part 2 of this interview. So click on the link in the description to watch that. Let's get started. How could we have prevented this pandemic from getting out of hand as it has? What lessons can we take for the future?
So the big question is, could we have stopped the kind of animal-human interaction that likely led to SARS-CoV-2 or an ancestor crossing a species barrier? And one of the important things to understand is that this crossing of species barriers is something that happens all the time. A lot of it goes unrecognized because many of the bugs that come from animals into humans or go from humans into animals tend to be host restricted, which means, if they go into a foreign species, they can't necessarily cause disease. So what we need is both for the jump to happen and for it to be an organism that can cause disease in a different host. And in the last 30 or 40 years, we've seen a lot of this happening. And the reason that it's happening is because humans are coming into contact with animals that they are not familiar with. Right now, we are in a situation where mostly what you will see is pet animals or livestock animals that we've lived with for a long time. But when you begin to talk about animals that we don't come into contact with on a regular basis, and the frequency of those contacts increases, or the diversity of animals that we encounter increases, then the likelihood of these jumps happening becomes great. What's driving that? Couple of things. One, of course, is the fact that climates are changing. So that means that we have a situation where the whole ecology of the world, what was distant, is no longer distant. Forests are cut down, which means animal-human contact increases. Within those forests, you have species like, for example, mosquitoes, which used to be limited to really around the equator, are now spreading into temperate regions as the world warms. So there is, you can't say if we had done this one thing, we would have prevented SARS-CoV-2. We would have needed to change the whole global architecture. So I think that rather than thinking about prevention, we should be thinking about what allows us to limit damage, what allows us to be prepared.
Okay. So what does allow us to be prepared?
Thinking about public health instead of thinking only about disease. So mostly when we think about medicine, it's about when I'm sick, I go to a doctor. And in general in India, we've got this mindset that you go to a hospital or to a clinic or to a specialist. 95% of the disease that we have, that's not really appropriate. What you really need is a frontline doctor, somebody who can manage things that are minor as minor illnesses. You don't need a super specialist to be able to handle these kinds of minor ailments. Okay. But we practice very hospital-based medicine. We don't practice medicine that allows us to prevent disease or promote health. Though recently, of course, promoting health has become pretty big business. So I'm expecting that we'll see more of that. For public health systems to be prepared, there's a lot that needs to be done. They need to have trained people and they need to have capacity. There are actually very few states in the country where there is a public health card. So Tamil Nadu was one of the first states to actually have people trained in public health, managing immunization, looking at outbreaks of disease. But most other states in the country still don't have that. So it's like every time there is an outbreak, whether it's H1N1 or Zika or SARS-CoV-2, we tend to reinvent the wheel. Say, once again, we start from scratch and try and build systems. I'm hoping that this is a big enough hit that the next time around we will be better prepared, whether that is with people who have an understanding of how to diagnose and control disease, as well as people in the lab that know how to characterize organisms and infectious disease modelers that predict what is likely to come, at least in the short term, if not longer than that.
Okay. Building off what you just mentioned, you're hoping to see better healthcare infrastructure in the future because COVID has been so impactful. The success of the global initiatives to create vaccines and therapeutics and information for COVID and its prevention methods, do you think that may have had a more long-term positive impact in enhancing the popularity of science, of biomedical science as a career amongst?
Well, I can tell you that medical school enrollments in many parts of the world are up, and public health educational programs are being oversubscribed. So I certainly hope that that is something that is maintained over time, because without having good health, as we know now, there's very little that you really can do.
Yeah, that's very true. Why do you think it's important? Why do you think you want more people to be pursuing this?
I think because we haven't invested enough in prevention. So if I was to give you a choice, here's something that you can do that will keep you well. And here's something that we will work on to cure you when you become sick. Which one do you think we should be investing in? I think we should invest in both. But what we've done largely is invest in the second category.
Okay.
We have almost 300 diseases that are vaccine preventable. We actually have less than 20 vaccines that are used as public health intervention tools on a large scale. So the opportunities for prevention are there, but we don't necessarily invest in that in the way that we should. Okay. And the argument is frequently made that if you use preventive strategies, you are applying them to healthy people, so therefore you need to distribute them to the entire world. Whereas if you're relying on curative strategies or therapeutic approaches, then you only need to direct them to the fraction of the population that becomes sick. But in my thinking, it's better to prevent illness than to try and manage it when it becomes severe.
I feel like that's what every doctor will say.
Unfortunately, that's actually not the case. So many people have trained in medicine, and they've trained, as I said, in hospitals. So they don't have an understanding of mild disease, and they don't have an understanding of communities and how they function.
Okay.
So I'm actually very lucky in having a broader perspective, because I studied at CMC Vellore, which is one of the few places that sends its medical students out into the community. So you get to see how people live, you get to see how much they spend on healthcare for their families and how catastrophic illnesses can be if they become severe. But you also get to see from the hospital end of things that the hospital is the top of the pyramid, the severe disease. Yeah. It doesn't milder disease in the hospital. So when you have doctors that train only in hospitals, they know how to recognize and manage severe disease. They are in many ways less effective when it comes to managing milder illness, because by and large, we don't have this practice of family medicine that is very widespread in other parts of the world. So, in the UK, you have general practitioners, in the US, you have your primary care providers. We really don't have that being done well in India.
Okay, I understand. Yeah, yeah. Now that we know what scientific research is capable of, you gave one example of improving our primary care systems, but what else beyond COVID do you think we should be aiming to solve? And what might that take?
We have no shortage of problems. So the first thing, of course, is to expand our spending base. We are in a situation today where in India, somewhere between 2/3 and 3/4 of all the spending on health is dependent on people paying out of their own pockets.
Oh,
And it doesn't matter for rich people, because needing to pay for a doctor's appointment or needing to pay for a hospitalization is not going to make you poor. It'll take a hit, but it won't drive you into poverty. Unfortunately, for the bulk of our country, that is not the case. It has been estimated that there are millions of people in this country that get driven below the poverty line because of health expenditures. If we have a country that is spending from the government perspective less than 2% of GDP on health, right? And that is about 1/3 of all the health expenditure. So if you add in the out-of-pocket expenditure that people do, we still spend less than 4% of everything we've got on health, right? That means that we are really treating severe illness. We are not doing very much for prevention. We are not providing the kind of care that keeps people well, or if you have chronic disease, allows you to be monitored. Most other countries, Israel spends very little, they say, on health. They spend 7.5% of GDP. The US spends over 16% of their GDP on health. There is no country that does well if the government does not invest in education and in health. And our government does not.
okay. Now, I would like to ask you a few more questions about your specialization. Specifically, what did your day at the lab look like before COVID? I mean, during the COVID time, you've been doing a lot of analysis on the pandemic situation itself as an immunologist. But what was it before COVID?
Pretty much the same. It's just that COVID is one more thing that we are studying. Okay. So before this, I've worked on rotavirus, on typhoid, on enteric infections in children. We study infections, disease, nutrition, water, sanitation, mostly in the community. And then there are a few studies that we do in hospitals. Most of our hospital-based studies are actually through networks that are across the entire country. So we'll have 25, 30 hospitals that with us study different causes of enteric infectious diseases.
Okay.
So with COVID, all that we've done is added one more pathogen to study. I was very reluctant to get into COVID because we really focused on enteric infections until now. And I thought a lot of people would step in and do the kind of big, ambitious studies that I think are really necessary for changing policy. But that was not happening. So finally, I've gotten some of my colleagues to take those on. And my job is just to support them and make sure that things stay on track and labs are functional and things are working out. But really, I'm at a stage now where I don't I've been at this stage for a while where I don't do anything alone. It's always with my colleagues, and I'm hoping that for the next pandemic, they will be the ones that will design and do all of the studies, and I'll be retired.
Okay.
This is Scienteens, where we meet experts and ask questions that can help you make the right study and career decisions in the sciences. I do this as a fellow student, and your support through a like and subscription will give me and everyone contributing to this channel a lot of encouragement.